Hello and welcome. The Indian Council of Medical Research, the body that governs all the advice that's being given in COVID-19 treatment and other treatment protocols, has released a new set of protocols on the 23rd of April. Now, many of these are the same that were announced in March 2020. Now, that in itself is raising some concerns. Now, many doctors are also prescribing medicines like hydroxychloroquine and favipiravir and Ivermectin, which are not found to be effective. Now, some of those are recommended by the Indian Council of Medical Research, some are not and are prescribed by doctors and physicians, particularly at an early stage when confronted with patients having COVID-19 symptoms. Similarly, plasma therapy, again, another response in hospitals which perhaps does not have much scientific, at least globally, much scientific support. So the question that is really coming up now, as there's a lot of information flowing in from other parts of the world, including well-meaning doctors in the United States or countries like the United States, is how should we be as patients in India, particularly at a crisis time like this, looking at these suggestions or these inputs? Are our medical and clinical conditions fundamentally different, and therefore what is being suggested elsewhere does not apply? Or are there some similarities that we should be aware? And finally, and therefore, how do we avoid the panic situations that we are clearly seeing with people lining up to buy medicines like Remdesivir, which clearly now both everywhere in the world, including in India, is admitted not to be a cure and only perhaps works to reduce time spent in the hospital. So to discuss this, I'm joined by two well-known doctors, Dr. Gunjan Chanchalani, a consultant intensivist at the Cumballa Hill and St. Elizabeth Hospital in Mumbai. I'm also joined by Dr. Sumit Ray, Head of Department of Critical Care at the Holy Family Hospital in New Delhi. Thank you both for joining me. Dr. Chanchalani, let me begin with you. So I think I've described what the situation is. How do you see it today, particularly given that we are in the middle of a second wave, also with definitely a far more infectious and deadly mutation compared to wave one?
So we definitely are in a second wave, and the main problem that India has is the lack of resources. Okay, and as you have already said, most of the medicines that we are prescribing probably are not indicated. And COVID is a viral disease which the body itself learns to take care of. And what we need to do is just give enough control of and enough antipyretics to control the fever. Okay, and once it is only the second week that there is a more inflammatory response or an immune response, when we need to intervene and give medications like maybe steroids and remdesivir when people have drop in saturation. Otherwise there is no need to really go for any over the counter drugs or any medicines which are ineffective against COVID.
Okay, Dr. Ray, how are you seeing at least the initial responses?
Right. So, as Gunjan said, we don't need to give any antivirals. No antiviral in the early phase like Faviflu, etc., has been shown to work. There is no evidence to support it. We need antipyretics. We need fever control. But having said that, if there is a persistence of high-grade fever, and there is breathlessness, etc., and there is a more inflammatory response, we need to intervene. As far as remdesivir, as you said, goes, there is evidence to suggest that it only reduces the length of stay in the hospital. It's not a life-saving drug, and it is important to tell everyone that it is not a life-saving drug, and particularly which subgroup has it shown a reduction in length of stay. The important part is that it's the only subgroup are those who are on minimal amounts of oxygen. Those who are not on oxygen do not benefit in reduction of length of stay in the hospital. Those on high oxygen support or on the ventilator, this is not a life-saving drug. So do not run around trying to find this and waste your energy and time and money to get it if your loved one is critically ill. It is only in those who require very low amounts of oxygen, 2 to 4 liters maximum. That's the subset analysis which has been done. So that's about remdesivir.
Right. Okay. So let me compare. Yeah. Go ahead.
No, I was just saying there was an interesting article in New York Times which said remdesivir drug in search of a disease. So it failed in Ebola, it failed in MERS, it failed in SARS. But unfortunately, to tell you honestly, even we are sometimes pushed to prescribe it because the pressure is so high And if the patient is not doing well, the pressure is even more. In spite of explaining to a lot of families, we end up having to do it. It's unfortunate, but that's what I'm saying honestly, that we end up doing it in spite of explaining to lots of families. Some families accept it, and some families say that, give it, my loved one is very sick, please give it. And I mean, medicine unfortunately doesn't work like that, but we are almost forced to do it.
Right. Yeah, and I'll come to that in a moment, Dr. Ray. So if I were to go back to the indiacovidsos.org, Dr. Chanchalani, so the treatments they say are not routinely advised are Ivermectin, hydroxychloroquine, convalescent plasma, vitamin C and D, itolizumab, and lopinavir and ritonavir, favipiravir, and so on. So basically, most of these antibiotics are not advised. Whereas the ICMR, for instance, says for mild disease, it recommends Ivermectin 200 mg mcg once a day for 3 days. It recommends HCQ, that's hydroxychloroquine. So why is there such a difference to start with? And also, my other question that I started out by asking, are we fundamentally different?
No, we are not fundamentally different. It is just you have to, you are kind of taking the information in the wrong way. It is a misunderstanding, and Dr. Sumit Ray used the term very correctly. Unfortunately, we are doing all these things because we are under the pressure of treating. We are under the pressure of lack of resources and the poor healthcare development that is there in our country. So that is the reason we are under a pressure, and we are using multiple drugs. Even today, when I get a consultation and when I do not really prescribe any antibiotic, I'm actually questioned what was the consultation for. But actually, anything that works in COVID, it is to decrease the inflammation in the first week, to keep the fever under control very tightly, keep the patient well hydrated. And only if he has an immune response in the second week do we need certain medicines. And which of them, the most important probably today, is steroids and nothing else. And that too in the right dose, no overdose of the steroids per se. So ivermectin, doxycycline, HCQ, all these drugs have shown no benefit of using in COVID in any of the researches.
Right. So, Dr. Ray, now where does the problems then start? So patients come and put pressure on you because they either, see it on WhatsApp groups or someone tells them. Or obviously at a physician level, a lot of prescriptions are happening, which I know for a fact from friends who've had COVID, that they were prescribed Ivermectin, and many of them did this little search and said that, oh, but it's not being prescribed elsewhere.
Right. So the interesting thing is, it is a bit of a chicken and egg situation. There has been prescriptions which, if you don't, sometimes because people are scared of COVID, they want some prescription. And if you don't give a prescription, there are other doctors, physicians who have given a long prescription, and they feel that probably, that patient feels that they will get better with this bunch of medicines. It's a kind of a feeling of safety that they get. As far as ivermectin is concerned, there is only one study from Bangladesh which has shown a retrospective study, some benefit. So that is the problem, is the fear that they have to be hospitalized, that our healthcare system, as Gunjan said, is not good enough to handle once you become sick or you will not get a bed in the hospital, that one tends to expect more medications to be given even pre-hospitalization, so that you don't end up in hospital. And then again, because it's not a good public health system, there is over privatization of the healthcare. So there is also a kind of in spite of all the there is a competitive edge to prescribing also, which also makes the situation even more complex. Already a difficult situation, even more complex.
Right, and Dr. Ray, and to you and to Dr. Chanchalani. So now you've had the benefit of, I'm sure, hundreds, if not maybe thousands of cases that have passed through in the last year. What's your sense? I mean, would you say that many of these medicines that were prescribed, which you would have ideally not liked to prescribe, have worked at all, or either way it would not have made a difference, or maybe there is some chance that they could have worked?
Should I take it first? Or sir?
Yeah, go ahead. You can go first. Yeah.
So I have actually prescribed these medicines in the initial wave, and I have used it. I would not say I have not. And this wave I don't prescribe it to anybody. And honestly, it makes no difference. It makes no difference to the severity or the possibility of that patient worsening in the second week, or the immune response that develops in the patient. It makes absolutely no difference. It is just about gaining the confidence in your patient that you don't need that medicine. And yes, I do get calls back, madam, you didn't write ivermectin, my neighbor was given that, my cousin was given that. You know, that is always there, but it is just gaining the confidence of your patient and telling them that all these will not work. And once they are confident, they follow you. And believe me, I have not seen any extra worsening after not giving these medicines. Rather, I
Okay,
see more
Doc-
for people who have given it. Like I have used Fabiflu, as I said in the first way. So many patients did complain of high uric acid. They had a lot of nausea, gastritis, and I think life was difficult for them. Comparatively now, all my patients are eating well and they do well.
so you're saying in a way they're recovering better, the quality of
They are
recovery is better?
recovering better. Yes, yes, the quality of recovering is better because we avoid the side effects that are there due to these medications. I mean, gastritis is the most common thing. Many people complain of vomiting, not able to eat food because of the gastritis that they have, because of giving some prescriptions are as long as giving all of them together, whether it is
Yeah.
ivermectin, Fabiflu, everything. So with that, definitely your body undergoes some change. And here, when we just advise them some supplements and good diet and maybe good hydration, they are quite happy. And in fact, I feel it reduces the severity in the second week. I mean,
Okay,
that's
Dr. Ray, your
my
experience?
observation. Sir will be.
Yeah.
Right. Dr.
No,
Ray?
I've never used Faviflu. Never ever used Faviflu, even in the first wave. I never used ivermectin either in the first wave, and basically multivitamins, etc. Ivermectin, I am to honestly tell you, I am prescribing once in a while here because of the pressure, and to tell I am an intensivist, as Gunjan is, and we are under so much pressure otherwise in the ICU that sometimes if patients or family and friends call up and say he has been prescribed ivermectin, I say, okay, go ahead, take it. I really don't have the mind space to argue. To tell you honestly, not in the ICU. I've never prescribed in the ICU. It's only earlier in the OPD basis. I don't have an OPD, but on the phone. And ivermectin, 3 days, 12 milligrams. And I say, look here, if you feel nauseous with this, stop it. It is probably not going to benefit you. But if it is somewhat on the insistence of family that I have ivermectin, but I don't think it benefits anyone. The evidence is very, very weak for it. And Faviflu, there is no evidence. There are 2 studies which were done, which had, very strong bias in the studies and very poor quality studies which were there. Yeah.
Right. And if you were to look back at all the patients that you've treated in the last year, and you would also concur with Dr. Chanchalani that in most cases there's either no impact or negative impact?
No impact, I think. No impact at all of these drugs. Absolutely.
Right. Okay. So let me come to a slightly more larger, maybe even philosophical question. Right. So in some of the Western countries, the healthcare response is different. I mean, if something goes wrong, you call a 911 and then an ambulance arrives and then you're taken care of. And as you were pointing out earlier, that's not the case in India because the trust in the system itself is so weak. How do we then address this, almost chicken and egg situation, again, to use your words, of the trust in the system versus, let's say, the lack of trust, which leads us to maybe over-medicate or over-prescribe?
It's to me.
Yeah, go ahead.
Yeah. So obviously it takes time. It's at a personal level, you can improve the trust by trying to take time and explain. And as I said, in the previous surge, I had more time because the surge was not so bad. I had more time to explain to people. And that's why I never used any of these drugs. In this surge, Faviflu, I say absolutely out and out no. But ivermectin, it's almost like you're balancing things out. But that's one aspect. It's a personal aspect. The other aspect is how we deliver healthcare in a country. I mean, it's not just about prescribing practices. It is also about how healthcare is delivered. On that depends so many other factors. Other factors which are even more important, like triaging, like that, which patients we go up to which level of support. Even advanced healthcare systems like Italy and NHS did that. In spite of the the equipment they have, the beds, number of beds they have, they did it. You have to triage. In the Indian context, it is so difficult to explain triage to that a person who is younger, who has more chance of survival, has to be given preference in if there is a shortage of resources, over a person who is much more elderly with much higher number of comorbidities, who has lesser chance. So it is difficult. It is not because people, it's because people lack the trust that this decision is being made because maybe I don't have the money, or I don't have the resources, or I don't have the contacts in the Indian context to get the best, and that is why it is being given to somebody else. While a good public health system like the NHS or the Italian system, the trust in the system is so high that people accept these things. They say, okay, we understand and we go by it. I mean, so the lack of trust in the system, and that is basically because of an over-privatized system. Healthcare, whatever, I mean, the best healthcare deliveries are those which are good public health systems for all levels of countries, for rich countries, for not so rich countries, and for poor countries. Wherever there is good public health delivery, I mean, overall health delivery is better. Even if we take our country, the examples are very clear. Kerala and Tamil Nadu do much better in all indices because they have much better public health systems. The faith in the healthcare system also is much higher there. We don't have to look outside the country. In our neighborhood, if we see Sri Lanka, it is so much. So all these factors kind of coalesce to kind of bring forth these problems that we are talking about.
Right. And thank you for that, Dr. Ray. I mean, this is very important to understand and know as well. Okay, so we're running to the end of our discussion. So let me get a quick sum up from both of you, and let me go with you, Dr. Chanchalani, first. So where we are today, I know you're in Mumbai, and Mumbai things are, at least at this point, have steadied a little bit. What would you advise patients who are obviously contracting, because the cases are still high, contracting COVID, and how should they be going about it, and what should they do or not do? And I'll come with the same question to you, Dr. Ray, after that.
Okay. So about the patients, so Mumbai situation is comparatively better. We are not in as much a crisis. Rather, we were never as much a crisis as compared to other states. Okay, so we managed, our task force probably managed it quite well, and the lockdown has definitely helped. But the only thing that I can say to all the patients is that please don't panic when you're detected positive. Follow your doctor, monitor yourself, monitor your own oxygen, monitor your oxygen on exertion, that is a 6-minute walk test. And only when the oxygen drops, report to your doctor and get admitted or take oral medications which are required. Panic is the worst thing that can be there. Have faith in your doctor is the most important thing. The very fact that people are using all these over the counter medicines or comparing with others is because they are panicked. So that panic is not required. COVID, in more than 95% of the people do not even require admissions. Okay, it can be managed at home. It can be managed quite well, and good number of people get well at home. So avoiding panic is the most important thing. Avoiding, these talks about each other, that how he worsened, because the numbers are so high. We have much more worsened healthcare system during our dengue epidemic, which we have in every monsoon, though we didn't see it in last year. But then there is not so much panic. Okay. The reason being, we are so used to it. Now this is new, and the panic is what is driving everybody crazy. So just calm down, follow your doctor, and report to him on a regular basis. It should not be that I'm checking my oxygen today and then I'm checking it after 8-9 days. So every day monitor yourself, eat well, drink well, and you'll be fine.
Okay, Dr. Ray.
So yes, one is monitoring oneself with also lab tests which the doctor prescribes, and tracking the course of illness. See, what happens is exchange of information with the problem with COVID is also the infodemic, right? People who have not been aware of so many diseases which happen. I'm not blaming anybody, but because you see, as intensivists, we have dealt with critically ill patients in earlier also. People did not understand the pathophysiology of a disease process so well. Okay, they don't understand. It's complex. It takes years of training. What has happened with COVID is that there is somewhere out there certain information which makes them panic because they cannot analyze and contextualize it. You see, we used to say that in our medical school, the third year syndrome. When we were third year medical students, we were first time we started reading the clinical conditions, and we used to feel when we read it that we are having all the diseases which are described. That's what is happening to a lot of people, that the severe illness, so 90%, as Gunjan said, will not worsen. 8-10% will get hospitalized. And the patterns of disease process is different in different people. So that's why the tracking the disease in each individual by the doctor, with the help of the doctor, is important. And for most people, it will improve on its own with some, nutrition fluids and some, supplements, vitamins, etc. And for others, if you track it well, yes, early hospitalization in that subset. But just because you have certain test number high is not an indication to be admitted. As Gunjan said, your oxygen levels, if they start dipping, you get breathless and you have persistent cough and high grade fever, yes, you have to track it with your doctor. Do you need hospitalization or not? 90% will not require.
And you're saying this, Dr. Ray, I mean, you are in Delhi, and you're saying this because I know the moment, for instance, we sign off just now, you're going to start getting calls. So you're saying this even at this point where there clearly seems to be a huge strain on the system, that these general rules would apply.
So the general rules apply. Okay, the general rules apply, but what is happening now is the numbers are overwhelming us. So if there were 10,000 cases, then only if you say 10% get hospitalized, 1,000 per day would get hospitalized. Now with 25, 30,000, 2,500 every day. And those who get admitted, average length of stay is about 7 days. So the system has got choked and blocked. Patients who go into the ICU don't move out for almost 3 weeks. So at every level, the system is blocked and choked. So that is why the panic of not getting beds, and the only way to reduce that is logistical improvement, surge capacity build up, increasing the number of hospital beds. Actually, to tell you honestly, it is also not just hospital. There are not enough hospital beds. What we have to do is look at it as like a disaster at this moment. Okay. So one end is to say that do not panic, but yes, people will panic in this condition when beds are not available. How do you improve that? Is you as a government, they have to build in, like an earthquake. What do? You bring in prefabricated hospitals with staff, with machines, with ventilators, with staffing, and start it. That is what has to be done in certain areas where the numbers are more. That's the only way. And also reduce the numbers at the back end by lockdowns, etc. So only then will this level of panic reduce, and then actually better sense will prevail among doctors and patients. Even doctors are panicking in the sense who are in general practice. They don't want their patients to end up in hospital searching for a hospital bed. If they ended up in hospital, it would be okay. They are searching for hospital beds and dying outside hospitals or in casualties because there are no beds available. That adds to the panic. So it's very easy for somebody to say that we should not panic, but it's understandable that it's happening. And the only way to stop it is stop the surge on one hand and build surge capacity.
Right. Dr. Ray, Dr. Chanchalani, thank you so much for joining me and sharing your thoughts candidly. And I do hope to speak to you again. And in the meanwhile, I wish you and your teams all the very best in fighting this dreaded disease. Thank you so much.